Yeah, welcome back, everybody. Hope you all had your supper, meal, some refreshments, and we are energized to go back to understanding the basics of implantology. We have learned a lot regarding the planning, the bone morphology, the fixtures, the type of fixtures, the impression making, and we will also see the hands-on in a very short time. Before that, we would like to also just introduce you to the BV implant system because that is something which we should know before we get into any using any system. You should know how good the system is and what are the components, and then understand because as that will help you in treatment planning. So let's begin with the basic introduction. This is how the implant system is comprised of A, the implant fixtures, B, the healing abutments, which is used during the second stage, then C, the impression copings, as I said, long and open and closed, and finally the abutment, which will receive the prosthesis. Implants are followed by immediately either cover screw or healing abutments, and then we come to the level of going for the fixture and abutment interface, where you have the transfer abutment, in that you have the straight and angled. You have temporary cylinders sometimes if you want, if you have done a FMR case and you want to give the patient convert their existing denture into a hybrid prosthesis screw retained on multi-unit abutment, then you can use that also. You have multi-angled abutments. You have the tie bar abutment, the tie base abutment, and you have the equator abutment, which is used for overdentures with the silicone rings, which act like the friction. These are the basic implant sizes. The mini implant 3.5 with the cover screw and a yellow coding for the entire drill system, implant system, as well as for you to understand and identify what implant you are doing and what line of drill sets are you supposed to be used. Second is the implant diameters 40, 4.5, and 50, which are the regularly used diameters. And the lengths, as we all know, start from 7 mm, 8.5, 10, 11.5, 13, and 15. And lastly, we have the wide implants, which are the 6 and 7 mm diameters. They can be used in posterior areas where we have low RBH, that is residual bone height, and we want to still use an implant for stabilizing your prosthesis at the distal end. So you can, what we call are the ultra short wide implants. Short because we will use them as 6 mm by 6 mm in length or 7 mm max. You don't want to drill a 13 mm 6 diameter implant. So again, these are the codings. So you can go through it with the brochure with your distributor or through the company channel directly. Again, the same codes, length 4.5, 50, 60. Yeah. Then what are the features that we look for implant? So as we said, a conical implant or a root form implant for the good initial stability, self-tapping groove, easy to implant in hard bones, applicable for immediate and early load bearing, and double thread design saves implantation time. What do you mean by double thread? That the cervical end and the coronal end of the implant have a little different thread design and pitch, which allows for initial good primary stability and BIC, that is bone implant contact ratio. How to choose implant? This was one of the questions also that we have received. So I think so this should help answer that query. Basically, as we said, the prosthesis guides the implant fixture and implant design that you would like to choose, the location of the implant that you are missing tooth that you are planning to replace. So generally, we are, as I said, that it's not a benchmark, but a 40 by 10 mm or 11.5 mm is an ideal implant, which gives good primary stability initially, as well as has a very good survival and success ratio in terms of the longevity of implants. Like you have seen the X-rays that we showed you, most of the implants are in that range, that diameter, and that length, which have shown almost zero to near zero bone loss and good functional efficiency in the intraoral scenario. But mainly what you have to decide, this is how you will decide that if you have a single missing tooth, then you need to keep a minimum distance between the natural tooth adjacent surface and one of the implant edge as 1.5 mm, and that is applicable on either side. So naturally you have to have minimum of 3 millimeters plus a 40, so 7 millimeters inter uh, dental distance, that is between two teeth, adjacent teeth. Also, when you are looking at the diameter, you should at least try for minimum of 1.5 to 1 mm of bone around the periphery of the implant, especially at the coronal edge where the tissue, where we are submerging the implant. You can sometimes have more bone around the middle third or the apical third because of the anatomy, but at the coronal third, we should at least have 1.5 millimeter bone all around, which gives good stability and also ensures that the occlusal loads are dissipated in such a way that there is minimum crestal bone loss. If the bone type is thin or you have very less bone, then the chances of crestal bone loss or vertical defect increases. So this is how you try to plan and decide what implant size that you would go. Length would be easy to manage either through radiography, and similarly, if you do CBCT, that is a dental computed CT, then you can also see the width of the implant and decide what diameter would be best. And remember that we should at least have about 1 to 1.5 mm of bone all around the implant. And between two implants, you should have a minimum jumping distance of 3 millimeters. That is 1.5 from each side, each implant. That is how we come to the 3 millimeter figure. So this is again showing a similar scenario that the distance between two adjacent implants or an adjacent natural tooth should be this. This allows for sufficient soft tissue formation between the implant bodies. Again, what I was saying, that ensure that the bone wall is 1.5 millimeter or more. If not enough, ensure that the lingual side is 1.5 and the labial side can be grafted with your GBR material, which can be autologous bone or alloplast or a xenograft, depending on what is available and the time that you can afford for uh, doing the second phase. So you should not implant too close to the root surface, and that is where exactly the parallel pins help. After your initial guide uh, for the lance drill or the twist drill, you are supposed to take a parallel pin radiograph to ensure that you can understand what angulation your osteotomy is going to proceed in, and if required you can do some course correction with the subsequent drill, either the twist drill or the final drills. But if you end up violating the PDL space of adjacent tooth, then that can lead to flare-ups on the tooth, and patient will come back with a lot of pain, and you might have to do intentional root canal, and hopefully that settles the pain. Otherwise, you might even end up removing the tooth. Also, at the same time, you have to remember that X-ray is a two-dimensional radiography imaging system. So a lot of times when you are doing a upper first premolar and you have a canine root, you might feel that the canine root is very much in close proximity to the implant surface, but it can, in three-dimensional, it might not be a similar case. So you have to always understand spatially in what angle and what position you are dealing with. How to place your implants in case of more than one or two missing teeth or three missing teeth. This is how you can do a bridge work, which is on similar lines like you would do for natural teeth. You might need one or two abutments. If it's a long span, then maybe three abutments to ensure that the forces are well divided. For posteriors, you can have up to one tooth missing and two implants. If you have three teeth, you need two implants minimum. So the BV packing system is as we had shown, and we will show you again also that it comes in triple layer, the box, the blister pack, and the final uh, packing, which contains your implant with the implant carrier, and the purple thing that you see is the cover screw over here, which is to be used for each case individually. And then what you need is the impression coping, lab analog, or the implant analog, and the transfer abutment as the final. You need the implant carrier, which is short and long depending upon the mouth opening that you have. Common types of implant, we have seen the diameters, how to choose a healing abutment. This is also equally important as much as choosing an implant, because if you want to have your prosthesis to look natural and have a good emergence profile, then you need to ensure that you do good soft tissue contouring depending upon the location of your implant. So if it's a molar, then you need to have a wide healing abutment so that the undersurface of your molar seats well in that area, and there is minimum food entrapment, which can eventually lead to peri-implantitis or a crestal bone loss. Especially similarly, if you are doing implants in the aesthetic zone, then you need and if you have placed the implant well at the crest and there is enough soft tissue available, then you need to have long healing abutments so that there is a good soft tissue formation and your emergence profile will have a very good natural look. This is what we also see for our natural tooth. Similarly, for implant as well, we are looking at the connective tissue at the implant and abutment or healing abutment level. Then about a millimeter or two of junctional epithelium, if you have that much soft tissue available to play with, and eventually the healing abutment should just come out of the surface of the mucosa, either at the level or little out, to ensure a good healing. These are fixture level cover screws. They are color coded based on the diameter. Purple is only purple for 3.5, and rest will be green, and the ultra wide will be probably a different color. These are the types of implant healing abutments. They come in different diameters. As said, if it's a lower anterior, you might need a 4.0. If it's a premolar area, then 4.5, 5.0. And if it's molar, then you might want to even go as wide as available, depending on the space. Implant, we all know the BV system is something where we are supposed to keep it at the bone level. So all the threads should be submerged completely, and the average healing time as per the manufacturers, this thing is for the upper jaw about 2.5 to 3 months. If you have good stability, lower jaw 2 months, and if you have a poor initial stability or you have done an immediate extraction case, then you should wait for about 3 to 4 months. All these also should be always corroborated with X-ray imaging to ensure that you are not disturbing the implant during healing phase, because if once you have rotated the implant when it is healing, then the only integration that you will end up is a fibrous and not osseous. Again, going through that, the healing abutment height, as I said, should be at the mucosa level or just a little higher. This is the ISQ device that I was mentioning, which lets you know what is the bone to implant contact ratio and how well your implant is integrated. And it can be used in to even understand if you are intending to do early loading, then you should have a good ISQ value to keep you feel secured and safe and have a good night's sleep, that okay, I can load this implant in the next 72 hours, and would like to see the patient after 4 months or 6 months or whenever he's back to for the final prosthesis. Conditions of early loading, I guess we all can now sum it up very easily, that the bone condition predominantly should be good, absence of infection, and initially stability should be more than 30 Newton centimeters. You should also ensure that patient does not have any parafunctional habit, no bad habits such as smoking or alcoholism, is a controlled medical patient. If even if they have diabetes or any other ailments, then all are under control. Then you can think of early loading, but as a beginner, again, I would say that we should go with the delayed two-stage protocol and ensure that your implant has healed well before you go for the prosthetic phase, just to avoid any negative scenarios, and that should take care of your initial cases. Impression taking, again, just going fast because we've done that in detail. These are the components that come with the Bioconcept: the closed impression coping on your left and the open impression copings on the right, the lab analog. They come with various gingival height depending upon your mucosa that is available, soft tissue. Similarly, you have these various codings according to which you have to order from your company. The catalog should be generally available to you from the company or the distributor. This is how you remove the healing abutment, install the open impression post, apply the light body, use the putty to take the impression, unscrew the open tray analog, fix the lab analog, make the master cast, and here you have your implant in the spatial orientation that you have done in the patient's mouth. Similarly, for the closed tray, I will show you in hands-on also, so it will be more easier for you to understand. Impression notes, open tray impression, we have again covered everything. Prosthetic restorations, cement retained, screw retained, and overdenture. So in cement retained, you have the transferred abutment or the angled abutment, which is also known as a stock abutment in many companies. In screw retained, you have the multi-unit abutment or the multi-unit angled abutments. They come in up to 17 and 30-degree correction. And finally, you have the overdenture equator or the overdenture ball attachments. These are the stock abutments that you see. They come in the various gingival heights, and length of the abutment as well can be of different. They come in 5.5 or 7 millimeters. So depending upon the interarch distance and the soft tissue, you are supposed to plan, or you can ask your lab to give you the order, and you can send the order to your company distributor and they will provide the same. As I said, 17-degree angled abutment. Similarly, these are the multi-unit straight and multi-unit angled abutments. They can be used, they are generally used to give processes for more than 3 to 4 implants or a full arch case. They are perfectly ideally suited for that because they help in correction of the angles. If you are doing a Malo technique where you have 2 angled implants and 2 straight implants, then the best thing is to have a multi-unit abutment rather than having straight or angled abutments and direct rigid prosthesis. This is how you can correct the angles in a full mouth case. Locator or overdenture posts. Company setting is 35 Newton centimeter to torque your abutment. These are the male and female of the equator abutment. They come with the silicone elastic cap. Again, you have to decide the gingival height that is available, and based on that, your coding will change. This is how it looks. Easily manageable and cleanable by the patient. The soft tissue, the male copings are placed, and you do a denture pickup with cold cure in mouth for best adaptability. That is called direct pickup. Better to do that rather than asking the lab to do the needful. Finish and polish, and the patient is ready to use the semi-rigid processes that you had planned. So that brings an end to all the presentations that we have so far. We had few more questions, so I would like to answer them before we proceed to the uh, hands-on. Regarding on how to choose the implant size, we have already clarified, I guess. Then the second question is after flapping, that is raising a flap, how to guarantee the aesthetic effect of the gingiva. So the ideal flap design should be a little palatal or lingual always to ensure that you have enough soft tissue on the labial or the buccal surface. And this is more important during the second stage when you are going to place the healing abutment, because that will ensure that you have enough soft tissue bulk labially or buccally for your processes to give a good emergence profile. The third is for implant placement, how can we efficiently avoid those areas at high risk? So again, this is what we call as plan and execute. So first is to understand and evaluate your case, understand your limitations based on your surgical skill, your level of implantology that you are practicing today. If you have done few hundreds, you will probably not feel anxious about a case like that. But if you are starting off with it, then we would look at a lower first molar as your ideal case to begin with. There is where there is enough bone height and volume available. But if you are posed with a case where there are anatomical landmarks that you need to worry, then either you can opt for a guided surgery with the help of a surgery guide, or as we said, use the depth drills which are allowing you to be safe from the anatomical landmarks. If your buccal or lingual orientation and angulation is good, then what you need to worry about is the vertical depth, so that you don't damage or touch any of the anatomical or perforate any anatomical landmark. For which, if you have a residual bone of say 8 mm only, then probably you will go in with a drill of only 7. And then you can, if you want to do a sinus lift and you are trained in that, then you can slowly increase your length slow by increasing the drill size or length, or you can use the available drills specially for such procedures where we have the casket called so called, where they are safe ended drills, and they come in various stoppers. So they start from 2 millimeter and go up to 13 millimeters to ensure that you don't violate any of the anatomical landmarks. So that is one way of thing, but predominantly it is the planning and evaluation before which you should not venture into the surgical phase. The fourth question is, how do you like Bioconcept dental implants and any special advantages? Well, as we said, we have this association has started very recently, but we have placed quite a few. I think so. I have already placed more than 35 or 40 units, and Dr. Rikin himself has placed about 60 or 70 units. So together, we have placed about 100 implants, and I think so. We are very happy because all these years, my primary system has been Austin, and if I have a system which is equally competent and compliant, then I wouldn't think twice before migrating. It is having all the patents, it is having all the certificates in place, it is having a good SLA surface, the design is good, the prosthetic options are good, it's digitally compatible with the new digital lab analogs. And as far as what we also see is company support. Though Bioconcept is, we are still planning to get them in India as well. Sooner or later, that will happen once the licenses are in place. But if you have your company, local company support, then you should not think twice before going ahead with that implant system. The last question is, in China, we usually use multi-units for full edentulous restorations. That is the all-on-4 or all-on-6 with the metal bridge. Can you share in India how do you use multi-units? Is it the same as us? Yes, doctors, it is more or less the same. The implant dentistry, fortunately, is well balanced worldwide. We are all learning and growing together, and we are using more or less a similar technology that is available to us thanks to our supporters, and that is how we also look at full mouth rehabs where we use the multi-unit straight and angled abutments for a full mouth case. We use either what you call a PFM, that is the metal framework with ceramic layering or acrylic layering. We also use PPMAs. We use graphene framework or titanium to make it lightweight, and they are doing wonderfully well. The only thing that you need to take care in such cases is that your mini screw that is used to hold the processes with your multi-angled abutment has to be passively fitting into your abutment. There is no strain on it, so that there is no screw loosening. And most importantly, your occlusion is balanced, and there is no lateral forces on your implant or abutment screw, which is most important because when you're doing angle correction, the forces which are directed on angled implants have to be designed in such a way that they go through the vertical axis of your implant. So these are the questions that we have received so far, and we will be soon going to the hands-on. Just allow us about 5 minutes. If the setup is already ready, we will just ensure that the video camera can capture the hands-on well and you have good audio. So this is a typical surgical setup that we have. And here is our patient for the day. We have quite a few dentures cases, sites, and we are going to plan and try and restore the lower right side, that is the 4, 5 and 4, 6 area. I was wanting to show this for a long time. So basically, when I had mentioned that how you evaluate a case and you might not have the opportunity of having a CBCT or something, then after having a master cast like this, and when you are making the surgical guide or putting two denture teeth over here and trying to make a denture so that that acts like a surgical stent through which you have your center holes to ensure the placement. There is something else what we used to do, I used to do to begin with, that is called bone mapping, where what we need is just a simple anesthesia needle, a rubber stopper which comes along with any uh, root canal instrument that we use, hand instrument. What you need to do is just try and feel the bone and see what length or what depth you have reached to hit the bone. And that is how you can do a three-dimensional bone mapping as well. And when you have your plaster model, then you know that cervical buccally I have about 4 millimeters, or on the crest I have about 3 millimeters of soft tissue. So if your X-ray is showing some amount of, say, 10 millimeters bone and you have about 3 millimeters of soft tissue, then when you are placing using your drill, you need to know that you will need to go about 13 millimeters to reach the 10 millimeter depth. So this is how bone mapping can help initial, first time or first few cases for you till you get a hang of using the implant dentistry, doing a regular implant. So now we come to the surgical phase. It's a hands-on. What we need to do is raise a nice flap. As just mentioned, we would like to not go to the center of the crest, but little more either lingual. If you are doing upper, then more palatal. If you are in the anterior, then again a little more palatal over here, so that you can have more soft tissue bundle for a good emergence profile. And try and have a nice clean straight cut, a small releasing vertical, and a little bit of cervical along the adjacent tooth to separate the this thing mucosa. You can use any soft your periosteal elevator and ensure that you reflect a full flap till you see full complete clean bone surface. There should not be any tissue tags as far as possible. I hope everybody can see clearly. So we have the flap which is raised and we have a good bone over here. You will have your associate generally reflect the lingual tissue and you are supposed to reflect the buccal tissue like this, or you can have a small soft tissue tag, soft tissue suture to ensure that there is no soft tissue which is coming when you are drilling. This is our implant handpiece. You have the typical implant handpiece, 20:1 reduction. The speed on my handpiece is about 1000 RPM. I This is my adjacent tooth, about 1.5 millimeters minimum, but I would like to have the center of the tooth. This is a premolar, first premolar. So I'm going more towards the center of the crest, a small ditch initially out, and then you ensure that you create a little bit of depth. After this, you will select the come out with rotation. The next is my 30. This comes only in 11.5 or 15 millimeters. So you are supposed to make sure that you only go up to the lower border of the black band. The next will be your 3.5. But what you should do at this point, you are supposed to take a parallel pin and take an X-ray for the angulation and understanding the orientation of your implant, whether it is parallel to your adjacent tooth, it is not touching the root of your adjacent tooth, and the proximity to the anatomical landmark, which will be in this case the mental foramen, because we are right above it anatomically. If we are in this area, then we have to be worried about the inferior alveolar canal. My next drill will be the 3.5 by 10. And your final drill that you do should be only one in and out as far as possible. A clean, and you can also reduce the speed if you feel that the bone is soft. If you feel that the bone is D1 type, then you can keep it at 1000 RPM. Otherwise, go at a low speed and you are out. So this is how your BV system implant is delivered to you. You open the packing, you have a sterile blister pack, you tear that, and you have the vial which contains the implant, and you open the seal carefully, and there's your implant with the implant carrier. You are supposed to keep everything ready before you open this thing, and your associate is supposed to remove the implant from the box and only drop this in your hand. This is the implant carrier driver which is connecting to the implant carrier. You open it, you snap fit it, and are you ready to go? No, you are supposed to check your implant motor settings. You are supposed to go to a pre-programmed setting where you are in the implant fixture placement mode, which is a speed max of about 25 to 30 RPM and a torque of 35 to 40. So here we start with the implant placement. As I said, keep it facing upwards, never downwards. Ensure there is no soft tissue entrapment. Slowly let the implant go in. Here we have the implant which has torque as far as the handpiece is concerned. So we are supposed to take the hand ratchet, torque ratchet, and the implant level driver. I will connect that in the in direction. It's written in over here, and this is out. So in direction, you will slowly torque the implant at a very slow speed. You don't want to cause overheating over here. You should not also ensure that you are not using too much torque in the patient's mouth, because that causes pressure necrosis. This is as good as patient shouting, "It is hurting," if it is so tight. Your implant is placed. You can see it is just a millimeter subcrestal, and that will ensure that even if there is a millimeter of crestal bone loss due to damage of the drills, you will still have implant which has healed at this thing. The second thing, as I had mentioned, what you have is hmm, the cover screw. You will use your screwdriver and pick up the cover screw and place it. This is how it is, and you will have a good soft tissue closure, a suture here and a suture here, and you are done. Now we will not do the suturing because we are going to show the second stage as well, and a impression making. So I will proceed with that immediately. I hope everything is clear so far. In the second stage, you don't need to create such a big incision. You can just manage with a small cut or a cross cut to ensure that you have separated the mucosa only enough to expose the cover screw, remove the cover screw, and then have a healing abutment, as I had mentioned, which is at the surface of the mucosa. This will allow a good soft tissue to form around the implant prosthesis when we are about to do the occlusal loading. So your patient has come after a week of your healing abutment placement. We assume that the mucosa has healed well. So what we will go is with a closed tray impression technique with the closed impression abutment coping. We will snap it and put the impression coping over here. Use the screwdriver to ensure that it is tight. In patient's mouth, after doing this, ensure that you take a radiograph to see the coping and fixture connection. There should not be any gap over there. So this is the closed tray impression. You check for the impression tray fitting. Assuming that it is fitting well, you will go ahead with the putty and soft tissue to take the impression. I am going to take an impression with this right now and then show an open tray jig making. Okay, we will not take an impression with the open tray, but we will show how to make a jig for the open tray. So I have the heavy body loaded on my impression tray. We just gently place it over here. Wait for about 5 to 10 seconds, not more. Ask the patient to do the tongue movements and all if you want to. And remove this. It's sticking because the model is a silicon this thing. You use the light body around the implant, impression coping, and you make an impression. You have to allow it to set well. Always take a little bit of light body on your glove hand to ensure that you don't remove the tray before it has set. Meanwhile, this is my pattern resin. As I had said, it comes in a light cure flowable form. I have another model where we had practiced sinus surgery. So you have to use some floss thread or you apply bond and you are supposed to put the light. Hmm? Yeah. I mean, so how this is helping now is when you have picked up the impression in your impression tray and you have transferred the lab analog to the lab, they have this spatial orientation. So whenever they check the master cast, your jig should sit in the same particular snap fit to ensure that your implant impression that you have given to him is accurate. So this is how it will be helpful. And if you have suppose multiple implants, then as I said, you can use floss ties to tie the uh, impression copings together to make a framework over which you will have your jig material fluid over it to ensure that it becomes rigid. A lot of doctors also use burrs to stabilize the splint. But if the bond fails, then you have to repeat everything again. So I rely on the pattern resin, but there is a small drawback. It's a light cure resin, so there is a slight amount of shrinkage that you have to understand and compensate for, which over a period of time you will get a knack of it if you continue to use a similar product for long. As mentioned, this will be your lab analog. You place the lab analog in the impression coping in a particular direction as the geometry allows, and the lab will pour a cast and you will have a ready implant model ready over which the processes will be designed. So this is what, yeah. So this is something that we don't generally cover in our basic implantology course, but we can always have an overview so that it helps every participant understand the drilling protocol as well as the basics of impression making, and then the prosthetics that you have to select or the lab allows you to select. We will now go back to the live